সুপ্রিয় চিকিৎসকবৃন্দ এবং সম্মানিত উপস্থিতি, সবাইকে আজকের বিডি ফিজিশিয়ানস কর্তৃক আয়োজিত ভালভুলার হার্ট ডিজিজ পার্ট 2 আজকের ওয়েবিনারে স্বাগতম। যথারীতি আয়োজনে আমরা বিডি ফিজিশিয়ানস এবং আমাদের আজকে সায়েন্টিফিক পার্টনার হিসাবে আমাদের সাথে যুক্ত হয়েছেন এসকে ফার্মাসিউটিক্যালস লিমিটেড। যথারীতি আজকে আমাদের মাঝে উপস্থিত আছেন স্পিকার হিসাবে আন্তর্জাতিক খ্যাতিসম্পন্ন কার্ডিওলজিস্ট ডাক্তার চৌধুরী এইচ আহসান স্যার। Dr. Chowdhury H. Ahsan sir, clinical professor of medicine, director cardiac catheterization and intervention, director cardiovascular research, University Medical Center, Las Vegas, Nevada. আমাদের সাথে আজকে চেয়ারপারসন হিসেবে উপস্থিত আছেন আমাদের সর্বজন শ্রদ্ধেয় ইন্টারন্যাশনাল রিকগনাইজড ইলেকট্রোফিজিওলজিস্ট ডক্টর রফিক আহমেদ স্যার। ডক্টর রফিক আহমেদ স্যার কনসালটেন্ট কার্ডিয়াক ইলেকট্রোফিজিওলজিস্ট, মেডিস্টার হার্ট অ্যান্ড ভাস্কুলার ইনস্টিটিউট, বেলটিমোর, এমডিইউএসএ। এবং আজকে আমাদের সাথে চিফ গেস্ট হিসেবে উপস্থিত আছেন আমাদের আজকের স্পিকার এবং আমাদের আজকের চেয়ারপারসন, দুজনের অত্যন্ত প্রিয় পাত্র এবং আমাদের সর্বজন শ্রদ্ধেয় বাংলাদেশ মেডিকেল জগতের একজন কিংবদন্তি প্রফেসর মাহমুদ হাসান স্যার। প্রফেসর মাহমুদ হাসান স্যার এক্স ভাইস চ্যান্সেলর বঙ্গবন্ধু শেখ মুজিব মেডিকেল ইউনিভার্সিটি, এক্স প্রেসিডেন্ট বাংলাদেশ মেডিকেল অ্যাসোসিয়েশন। এর বাইরেও মাহমুদ হাসান স্যারের অনেক পরিচয় আছে। আমরা আর কথা না বাড়িয়ে আজকের আমাদের সম্মানিত চেয়ারপারসন স্যারকে আমাদের আজকের সেশনটি শুরু করার জন্য বিনীত আহ্বান জানাচ্ছি।
Thank you, Ahsan. Good morning in USA and good evening in Bangladesh. Assalamu alaikum. So this is a wonderful forum that has been created, and I have participated in it, and I'm happy to see Hafiz joining this session. I'll tell a brief introduction of Hafiz. Hafiz is a graduate of Dhaka Medical College, a top student of his class. I met him in America. He's a very dynamic personality. He is, of course, professor of medicine, fellowship program director. Plus, he's the governor of American College of Cardiology Nevada chapter. As a matter of fact, he is the first Bangladeshi to be a chapter president in the United States of America. The most of all, Hafiz is what I have different kind of Bangladeshis, and I call some people true Bangladeshis. And there are few, and Hafiz is one of them. I mean, I'm not talking about people living in Bangladesh, people live outside the country, a true Bangladeshi. And one of my friend told that Hafiz is a soldier general. That means he works as a general, he works as a foot soldier. And that's him. He's my younger brother. I'm biased towards him, but I think justifiably so. He has been working in Bangladesh devotedly for the last 15 years. You don't hear about him because there are few of us who keep a very low profile when we go and work in Bangladesh. We go back and we do things, and Hafiz is one of them. He has been working consistently for the last 15 years plus in Bangladesh and teaching in his field. And today Hafiz is going to talk about valvular heart disease. And Hafiz, without further introduction, I'd like you to start your session.
Good morning, everyone. I hope that you can hear me and you can see my slides.
Yes, sir.
Can you see? You can see my slides?
Yes,
Yeah.
sir.
Okay. So thanks, Rafiq Bhai, for that kind introduction. And for the participants, I can tell you this. It shows you how much he loves me. And I clearly enjoy working with him. Rafiq Bhai has inspired us to give time for education, training, and research in Bangladesh. And I really admire him. And also I wanted to give thanks to Dr. Ahsan Khan and BD physicians that they are inviting me and they're doing this great work to disseminate education and play a significant role in terms of promoting education, medical education in Bangladesh. And it is really an honor and privilege to do a lecture in the presence of legend like Mahmoud Hassan sir. I mean, I can't tell you how much I cherish that because I know him by name from the time when I was a medical student. And later, I really had this opportunity to know him and meet him. So it gives me much pleasure, joy, and honor to do a talk in his presence. So without further delay, let me go over this part 2 talk, which is on mitral valve disease and aortic valve. We talked about the aortic stenosis and mitral regurgitation. Today, I'll go through this clinical presentation and some focus points in the management of mitral stenosis, which is not a very not a new topic for Bangladesh, and actually for US this is a little different perspective. But maybe we can start with a case and we can share this experience. 25-year-old female who is 33 weeks into her pregnancy became short of breath, and then heart rate 110, respiration 20, and then blood pressure 100/60. Physical exam reveals 2/6 early diastolic murmur at the cardiac apex. Which of the following is likely diagnosis? So this is a very basic stuff that we say a diastolic murmur is always an organic murmur. And when there is an organic murmur, that means there is underlying structural heart disease. You try to correlate this auscultatory finding and see whether you can diagnose something that is consistent with the auscultation. So clearly here, anyone to jump in that what will be the clear diagnosis here? I don't think we have any voting system, poll system. So this is
দেখি হ্যান্ড রেজ কেউ করে কিনা।
Okay.
আজকে কিন্তু স্যার আমাদের বেস্ট যে পার্টিসিপেন্ট হবে তার জন্য ডেভিডসন লেটেস্ট এডিশন স্যার আমাদের পক্ষ থেকে গিফট আছে।
ওকে
ওকে, ডাক্তার সারা আল রাজি, আমি স্যার ওকে একটু প্যানেলে আনতেছি। হ্যাঁ, ডাক্তার সারা আল রাজি, একটু আনমিউট করে প্লিজ গিভ ইউর ওপিনিয়ন।
Mitral regurgitation.
Okay, so it is a diastolic murmur, right? So systolic murmur during the ventricular systole, and that will be consistent with mitral regurg. And aortic stenosis during ventricular systole, it will be more in line with systolic murmur. But in mitral stenosis, in the ventricular diastole, there is problem in the feeling, and we see the low or hear this low pitch rumbling murmur. So this is actually mitral stenosis. And in this case, once we diagnose this mitral stenosis in a pregnancy, it raises question that how bad is the mitral stenosis? Will she be able to go through the pregnancy without any further issue? How we assess that? But the first step for the evaluation is that we don't miss the murmur and we don't miss the diagnosis of mitral stenosis. So let's look at another patient, 32-year-old with dyspnea hemoptysis, and the blood pressure is normal. The cardiac exam is diastolic murmur in the apex. A bronchoscopy was done because of the hemoptysis and the concern for malignancy. Echocardiogram will likely reveal or can reveal to explain the clinical presentation of shortness of breath, hemoptysis, and then diastolic murmur will be more consistent with the diagnosis of, again, mitral stenosis, because mitral stenosis can give left atrial enlargement because there is an obstruction, and the left atrial enlargement can give mechanical problem. It can give the pressure rise in the pulmonary circulation. It can give pulmonary hypertension, and it can ultimately give this problem of hemoptysis as well. We also see hemoptysis in cardiac situation like acute severe left ventricular failure when there is blood tinge sputum also coming out. So if we don't diagnose this right, we'll not be able to provide the therapy. So it is very important to understand the pathophysiologic basis, which I'm going to briefly mention in the following slides. But before that, I want you to remember this patient, which is patient 3, because that will actually inspire us that how we evaluate mitral stenosis. When we learn something, we have this question, why we are going to learn? Because we are going to learn because we need to help someone who came with symptoms to us. That is our patient. 45-year-old with the dyspnea, and there is exertional dyspnea. And if you always are familiar with the New York Heart Association classification, this is a simple classification, 1, 2, 3, 4, but it does have significant prognostic issues in terms of how the patients will do over time, just looking at the functional capacity. This patient had a loud first sound and a mid-diastolic murmur. There was an opening snap. That means under pressure discrepancy, there is opening of the mitral valve, and then there is a late systolic accentuation. So loud first sound, and then there is second sound, and after the second sound, there is an opening snap. Second sound happens because there is closure of the aortic valve, and then the mitral valve opens, and then you hear the diastolic murmur, and before this next heart sound, you hear the late systolic accentuation. And this is a maneuver that you all learned in the bedside physical exam class, and I would request you to practice that left lateral, bell of the stethoscope, and then breath held in expiration, and then you hear this murmur. That is the auscultatory findings. And then when we did the echocardiogram showed that there is pulmonary arterial systolic pressure increased with the exercise to like 70. And then the pressure gradient because of the obstruction across the mitral valve is 14 millimeter of mercury. Which of the following is the most appropriate course of action? Now, why I'm showing you this case is many of the participants for this class may not be involved directly with the advanced cardiology imaging and the management. But I think it is important to know what we do in cardiology after diagnosing a valve disease. You look at the patient, you look at the patient's symptoms, you look at the functional class, and then you evaluate the valve, and then you decide what therapy for that severe valve disease with symptoms would benefit the patient. And why we do that? Two reasons. One, that the symptoms are actually affecting the patient's life. And the second, if we leave this untreated, is going to cost the survival of the patient. So therefore, it is important that we do diagnose these patients, we ask for help, we evaluate, and we treat the patients. Generally speaking, as you know, that aortic valve has 3 leaflets, mitral valve 2 leaflets, the tricuspid valve has 3 leaflets, and the pulmonary valve has 3 leaflets. Only one valve that has 2 leaflets, and the valve area when it opens is actually 4 to 6. Tricuspid valve area is the biggest, and then rheumatic carditis and the rheumatic fever long-term can affect the valve, which means that acute rheumatic fever can induce inflammation, and long-term, it can give late inflammatory changes with fibrosis. So worldwide, in the adult population, we talk about mitral stenosis. The cause of mitral stenosis is rheumatic heart disease, rheumatic heart disease, rheumatic heart disease. Otherwise, mitral annular calcification or infective endocarditis by itself giving mitral stenosis is extremely rare. And the hallmark of rheumatic carditis is that it affects the valves, but where in the valve? The valve, mitral valve, has this called the annulus, then mitral valve leaflet, then the underlying chordae tendineae, and then the pap muscle, and then the geography of the left ventricle. When there is a mitral regurgitation, it is even more important for us to understand the mitral valve structural basis to figure out whether there is mitral regurgitation primary because of the mitral valve leaflet pathology, or secondary because of the change in the annulus or the LV geometry. Because now that we have therapy for the mitral regurgitation, that means valve annuloplasty, valve replacement, or valve repair, or percutaneous valve, or percutaneous valve repair, it is very important that we understand what is the underlying problem, because that will dictate what kind of therapy we can provide. In the case of mitral stenosis, long-term, chronic, there is something we describe in the echo world, that the anterior mitral valve leaflet appears like a hockey stick. And this is very characteristic because of this inflammation and the late inflammation with fibrosis make the valve appears like this hockey stick appearance. The two things happens that we need to understand. One is fibrosis and then calcification. The more the fibrosis, the valve can become smaller and cannot open. And if it cannot open, then in diastole, the left ventricular filling is impaired. And because it is impaired, it may cause the back pressure, the capillary wedge pressure high, and it can cause further back pressure, pulmonary vascular resistance. Because of the chronic pressure rise, PA, pulmonary arteries, diastolic pressure can go high, systolic pressure can go high, and then the whole brunt of the disease can fall on the right ventricle, because now right ventricle, which is almost like 1/3 of the size of the left ventricle, will have to deal with the cardiac output against the high pulmonary pressure. And that is a bad situation, because now the right ventricle will struggle, and you will start seeing all the effects of the right ventricular failure, such as jugular venous distension. You can see that the leg edema, the edema in the back, then you can even see liver congestion, and you can even see the pulsatile liver. So let me tell you about the hallmark of rheumatic mitral valve involvement. It is in the commissure. The commissural fusion is the hallmark. So when, unlike mitral annular calcification, the commissural thickening and the leaflet thickening and leaflet fibrosis gives rise to the mitral valve stenosis. Unlike the endocarditis, when the leaflets can be directly involved, leaflet can go or undergo perforation, or you can sometimes see non-bacterial thrombotic endocarditis or Liebman-Sachs, where these vegetations are on the atrial sides, and in case of Liebman-Sachs, it can be on both sides, but these are not typically commissural changes. When you see commissural changes and fibrosis and the tethering of the valve and then more narrowing, then you think that this is more of a mitral stenosis. So I described already to you that there is shortness of breath, and then there is pulmonary congestion, and you see the whole brunt of the disease. And in addition to that, this valve has consequences, the mitral stenosis, because atria becomes big. Soon the rhythm will change from sinus tachycardia to atrial fibrillation. These patients are at very high risk for stroke. All the stroke trials, when there is rheumatic mitral stenosis, the risk of stroke so high that they actually did not think that it is ethical to randomize them into anticoagulation versus antiplatelets, and therefore they are excluded. So when it comes to like significant mitral stenosis and atrial fibrillation, we always commit ourselves to prescribe anticoagulation to prevent the devastating effect of stroke. And then we deal with the consequence of the mitral stenosis. The consequence is, as I said, mitral valve will get worse and worse, or can get worse and worse. We don't really know why some develop this faster than others, but nevertheless, average 10 years, and then you see the natural progression of the mitral valve, which initially may have started as a clinical acute rheumatic carditis with mitral regurgitation, and maybe in some cases, mitral stenosis acutely. We call it Caricum's murmur. And then later on, it progresses into mild, moderate, and severe mitral stenosis. And that results in clinical scenario of heart failure, atrial fibrillation, complications from that, right heart failure, and then ultimately death. We talked about the physical findings of mitral stenosis, and also it is important to realize when we do the physical exam that are we seeing just the patient with mitral stenosis, auscultatory finding, physical exam, or are we also seeing the brunt of the disease that is falling on the right heart, and is there any right heart failure? Because that will wake us up for further evaluation pretty soon, so that we can evaluate the degree of the mitral stenosis and then give the therapy. It is a mechanical complications, and in the face of mechanical complication, when the stenosis is severe, it has to be mechanical. But if the heart rate is faster and then there is a less time for diastole, then we can control the heart rate and the patient may feel better. There is congestion, you can give diuretics, so patient will feel better. But ultimately, you'll have to think about what we can do to provide the direct therapy, the definitive therapy, which is the taking off this mechanical complication. There are a few things that I wanted to mention that in the physical exam, it comes or may come in the exam, that intensity of the diastolic murmur does not correlate with the severity. However, the S2 second sound and the proximity of the second sound with the opening snap, the closer the second sound with the opening snap, this more severe is the stenosis. And then the duration of the diastolic rumble can also correlate with the severity. And also you can see whether there is any complications from the valve, then you will understand that the valve severity is more. There is also another important thing that you may see in some patients, that it may coexist with mitral regurgitation. The apex, if it is shifted, the chamber, LV chamber size is enlarged, that means there is coexistent valve disease other than mitral stenosis. Remember, mitral stenosis somehow protect the LV, but when there is severe mitral regurgitation or coexistent aortic stenosis or aortic regurgitation, then LV is no longer protected and can start dilating and can have the LV failure as well. So chest X-ray can be helpful, but the real tool that we need to assess at the bedside is the ultrasound of the heart. And we need to make sure that the valve is significantly stenosed or not. We need to do the anatomy of the valve, and also we need to do the physiologic assessment of the valve. The mean gradient across the valve is important. We need to look at the pulmonary arterial pressure. We need to calculate the valve area, because the valve area is less and the symptoms are there. Those patients need intervention. And there is guidelines. If the patient is not that symptomatic and patient is stable, we don't need to be obsessed to do the echocardiogram every month. We don't need to do echocardiogram from one physician to other. We should be able to follow that up and see the progression and then intervene when it is needed. So not all patients will need immediate intervention, and the severity of the valve and the symptomatic presentation all are very important to consider. Now, antibiotic prophylaxis is not routinely mandated now with the new guidelines, as you know, unless there is previous history of infective endocarditis or there is a new mechanical valve implanted. So this is something that you always look for when you have a patient. And I tell you that if you cannot remember or you cannot memorize, generally speaking, I look at one thing. Is the patient symptomatic, or what is the data to support that the valve is severe? And then you go to class 3. Am I doing any harm? If the patient is not symptomatic and there is mild mitral stenosis, you can always negotiate with the patient and tell that, hey, we will be following you up. We'll be vigilant about the complications. Whatever I told you so far, this picture describes that all. The primary problem is in the mitral valve. Then there is mechanical obstruction. The pressure gradient across the left ventricle, across the mitral valve to go into left ventricle is going to go up. Left atrial pressure will go up. Left atrium is going to be dilated, and then it will congest the pulmonary veins. Then the PA pressure will go up. Because of the PA pressure goes up, the right ventricle will start to feel the pressure against which it contracts. Right ventricle will start dilating. Right ventricular pressure will go up, and then it will dilate the annulus of the tricuspid valve, and then it will leak. It will be making the tricuspid valve leaky. There will be tricuspid valve regurgitation. Right atrium will now get volume overload, ultimately pressure overload. Right atrium will dilate, and then right atrium, the pressure high in the right atrium will affect the inferior vena cava and then the leg edema, etc. So let's look at our patient from example 3. That patient, as I mentioned to you, that the PA pressure was high, and then with exercise went up further, and then pulmonary arterial pressure, and then there is a significant gradient. Remember, 10, 15 is in the moderate severe range, and patient is symptomatic. So is it time to think about mitral valve repair or surgically, or we do surgical mitral valve replacement, or should we do mitral valve valvotomy, that means plasty, or no therapy at this time, or we should need more information to decide what we do. Any thought on this? The way I have described this mitral stenosis to you.
Okay, I
Now,
feel
yeah.
two physicians answered.
Yeah.
Murad Mahmood said valvuloplasty, and Firoj Mondal said percutaneous mitral valvuloplasty.
Okay, so my question is that how we decide that? I think it is important because if we do percutaneous mitral valvuloplasty, we need to go through the interarterial septum, and then we put a device through the mitral valve into the LV across the mitral valve, and we inflate the balloon. But make sure first that the valve is not calcified or heavily fibrosed, because when you dilate, it can have complication. So it is important to have the, let me go to assess the valve first. And this is, yeah.
Can I ask you a question?
Yeah.
First of all, I mean, one question is the patient is symptomatic at severe mitral stenosis. So that is the reason that it requires intervention, something, right?
Right.
And the question would be that why this patient is 45, and I'm going to give you two patients. If this patient was 75,
right,
will the treatment change? Are we going to choose valvuloplasty replacement? What will be the reason for those?
Okay, so that's actually a very valid point, right? Because if we don't assess and then just recommend a surgical intervention, that means the patient is undergoing surgical intervention, and that the patient is young. What about the long term? The question is, can we avoid that and buy time by doing valvuloplasty? The question is, if we think that way, it is non-invasive, I mean, it is less invasive, it is not opening the chest, and we can do percutaneously, it will be better. But the question is this valve good enough for that? Because if the valve, and Wilkin actually was a fellow in Boston who actually developed this scoring system, looking at the valve mobility, the calcification, subvalvular thickening, and giving a score. But first thing, that if the valve is very thickened, calcified, and score is high, if we do the valvuloplasty by balloon, it may cause trouble. That means valve may undergo crackly valve mitral regurgitation, and that may be a complication we don't want. The second thing is that if you want to do like a surgical commissurotomy versus replacement, the more the valve the stenosed and fibrosed, then it may not sustain that. So therefore, what we do before we do the valve intervention, another important thing I wanted to mention, that we need to do cardiac catheterization, particularly in the elderly. If it is a 70-year-old, make sure that there is no coexistent coronary disease, but that is less of an issue for the mitral stenosis. More importantly, the physiology of the valve, we also try to do the gradient across the valve. But more importantly, I tell the fellows, now that we have echo and the transesophageal echo, we can get all of that by echocardiographic imaging. But in the cath lab, we really need to do few other things. In addition to the assessment of the coronaries, also look at the right heart and then see the right heart pressure is bad. If the right heart pressure is very high, no matter which way we do valve intervention, that patient may have subsequent complications from the right heart failure as we do the valve and the periprocedural complication. So this is what we do. We go, if the valve is good, that means the Wilkin score is low, and then chances of valve-related complications such as mitral regurgitation in the cath lab, which is something devastating, may need surgical intervention right away. We need to be careful about that. And to start with, if there is organized thrombus, we try not to do this. So this is what happens with the mitral valvuloplasty, that this is left ventricular end diastolic pressure, and then you see the wedge pressure, the wedge and the left ventricular end diastolic pressure. There is a difference. That difference is called the mitral gradient. And then this mitral gradient should be less than 2, 3. And when there is high mitral gradient, what we try to do, we try to put the valve balloon across the valve and inflate the balloon and see the gradient will become like normal. There is no gradient between the wedge pressure and left ventricular end diastolic pressure. That's the goal. So this is how it works. We balloon placement and then we inflate, but this is narrowing of the gap. The valve is now good. Patient is feeling well. In another patient, after the valve inflation, you can see that the left ventricular end diastolic pressure has gone up, but even worse, the wedge pressure has gone up further. And if you look at the V wave, now there is V wave, which you did not see before. That means the gradient has come down, but the wedge pressure has gone worse. And there is now a new V wave. That means the patient has developed severe mitral regurgitation. This patient may develop acutely frothy sputum and then soon may go into hypotension and die on the table. So this is therefore very important that we actually assess this valve before we embark on any kind of intervention and choose the right intervention. 75-year-old with emphysema presented with increasing dyspnea. There is a 2/6 diastolic murmur after an opening snap at the cardiac apex. An echocardiogram shows typical hockey stick appearance of the anterior mitral valve leaflet. The mean pressure gradient across the mitral valve is 7 and the mitral valve area is 1.2. What is the degree of the mitral stenosis in this patient? And what do you do? If you think about this, this is 75-year-old. As clinician, and particularly if you are the internal medicine clinician, you need to think about these patients. And always, if you are hands-on physician, we, the cardiologist, interventionalist, we are answerable to you. We need to have a very good reason to justify for intervention. At the same time, you also need to be very accountable that you assess this valve with our help. And then together, along with the patient, we can take a decision what is best for the patient. That is now.
Can I interrupt a second?
Yes.
One physician answered, Dr. Saidur Rahman Himmel, and he said it is moderate mitral stenosis.
Okay, I'm very happy that we are getting the message across, right? Because you look at the numbers, you look at the patient, and you assess. If it is a moderate stenosis, you can probably buy time. You don't need to jump. Remember, anything we do in this patient surgically maybe not so helpful to the patient. Now, exercise tolerance over time reduced. He has AFib. Mitral valve now gotten worse, and you are following up this patient. You follow the patient, the cardiologist followed the patient, and then over time, this happened. That the mitral valve gradient now worse. A right ventricular systolic pressure is 70. You did a cardiac catheterization, no significant coronary artery disease. You advise the patient at this point, continue with rate control at apixaban, cardiovert and add diuretics, consult surgery for mitral valve replacement, add diuretics, consult surgery for commissurotomy, add diuretics and proceed with mitral valve plasty. So these are the options that you will encounter. And why I'm bringing this up, because as the primary care physician or internal medicine specialist, you need to be familiar with this term because what we propose to you needs to make sense. Because sometimes we may be overdoing, or patient may be asking something that we need to answer logically. So let's look at this. Continue with rate control with add apixaban. This valve is now severe, and the newer anticoagulant we are trying not to give in these patients. And in the mechanical mitral valve or mechanical aortic valve, any mechanical valve, these newer anticoagulants, the apixaban, the rivaroxaban, all these are contraindicated because in the studies it showed that they had more thrombosis. So therefore, that is not a good option. Cardiovert and add diuretics. Some of them are logical, but you can buy time, but this is not going to help the patient long term or even intermediate term. And in a case of atrial fibrillation with mitral stenosis, left atrium dilated, cardioversion may not last, and then a diuretics is indicated to relieve symptoms, but it's not going to address the underlying issues. You can consult for surgery, and remember, when we consult surgeon also looks at us for the data, and surgeon wants to know what we want the surgeon to do. So it is a decision that we make together. If the valve has significant calcification, then commissurotomy may not work, and because the same problem as we have with the balloon valvuloplasty. And in this case, in the case of 70-year-old, the mitral valvuloplasty may not be the best option either. So therefore, these patients probably may need mitral valve replacement, but it all depends on the local expertise and what the surgeon will tell you in terms of commissurotomy versus mitral valve replacement. But I don't think that this valve will be a good case for mitral valve commissurotomy. Any follow-up question on that explanation? If not, I will request
there's no
you.
question about this. Yes, go ahead.
Okay, I will tell you that the American Society of Echocardiography and in general societies are now labeling these valve disease stages, and I call it at-risk valve. This is not just unique for mitral, for any valve. Who are at risk for the valve disease? Are the valve lesions progressing? And then the valve lesion progresses such that valve is tight, but the patient is asymptomatic, and then patient is symptomatic. So you need, when we see this valve like a stage D, it is like one-way ticket, and it is a problem because now we have no significant medical therapy that we can reverse, and that becomes a problem. So the societies are actually telling us.
Can I ask you a question, Hafiz?
Yeah.
Yeah. So, you put this slide, it's a very interesting slide. At the left, you said stage A, B, C, D.
Yeah.
And, this A has been added new. Can you
Yes.
just explain our audience what is the significance of adding this A and why we have this new classification? And it is not only for this, we use it for other cases, right?
Exactly. Exactly. Because that tells us that you as internal medicine primary care physicians and we as cardiologists, when we see a patient, we need to ask ourselves, when we assess cardiovascular, does this patient have any risk to develop valve disease? Or is there any early sign of valve disease? Because at risk, what we can do. And then once we identify that, we follow up this patient and see the progression. Is this patient in an accelerated curve in terms of progressing very fast, or this patient is in a slow curve? This is very applicable, for example, in aortic stenosis. Some people develop aortic stenosis and gradient worsens faster than others. We don't quite understand who progresses at what rate. But once we are aware, then we can make up a plan what to do. And then the patient now comes to you and already advanced valve disease, but remarkably asymptomatic. This is a challenge, right? because these valve problems will not go away and the patient is still asymptomatic. So you look for any therapy intervention that is very minimum and the benefit long-term is overwhelmingly high. And therefore you look for centers, expertise who can do this when the patient does not have that much symptoms, or you wait for developing symptoms. That is the main principle. And then when it is symptomatic, then you really need to do something, jump on, evaluate, and then do interventions. So that previous slide now translated into this slide, little busy, but the theme remains same, that you need to figure out that symptoms, valve issues, severity, and then coexistent comorbidities, and then decide about what kind of therapy. And this has to be negotiated with the primary care, the patient, and then expertise, what we have available. And if you don't remember any of this, whenever you are encountering, and I tell the fellows, there is no harm in opening up the book chapter or online access. Now with the Google, like 20 years ago when we were in the postgraduate course, we had to go to the library, find out evidence, research paper. I'm amazed. I don't even search PubMed. I just search Google. You can write anything in the Google. But I tell you one thing though, when you see the results in the Google, when you read this stuff, you need to check the source of the paper that you are reading, because you need to look at, is it from an authentic source that you are getting the online information. With that,
Hafiz,
I will spend the next. Yeah.
Hafiz, I want to stop you here for a second.
Yeah.
I want to go back to your first case.
Yes.
The first patient was a pregnant female.
Yes.
And she had no symptom before pregnancy.
Right.
That's my assumption. And of course,
Right.
during pregnancy, from the physical finding, we think this is mitral stenosis and confirm. So what happened? Why did she become symptomatic?
Okay. So in mitral stenosis, and for that matter, any stenotic valve lesion in pregnancy, the volume situation goes up. It can go that high now that your cardiac output goes high, and in a stenotic valve, that doesn't help. So now you are seeing that mitral valve disease that was there. Now that patient becomes symptomatic and brought to the attention of the physician. And our job is to find out that, is this valve at the current state good enough to let her go through the pregnancy, or is going to fail during this? Because the worst part of the pregnancy is during the delivery time, when there will be a huge fluid shift. And the third trimester and the end of the third trimester, it will be worse. And one thing that the patient do not do well in the valve lesions is the stenotic valve. In case of regurgitant valve, leaky valve with the high volume, pregnancy is probably a little better tolerated than the stenotic valve. So bad aortic stenosis, bad mitral stenosis, severe, and patient is in the second trimester, already symptomatic. These patients are labeled as high risk pregnancy. And you try to do everything that you can to prevent a catastrophe during the later part of the third trimester or during delivery. So this patient was assessed. It was mild. You need to communicate with the OB doc and then follow up. If the valve is bad and the severe, and the PA pressure also rising, then you need to do further assessment and see whether you can do valvuloplasty to bail out the situation so that patient can safely deliver the baby and continue the pregnancy. This
So,
is
Hafiz,
not an indication for termination.
Okay. So Hafiz, I have, before you proceed to the, because there are a couple of questions.
Sure.
I start with the baseline. So what I summarize from your statement is that it was a mild mitral stenosis, but the blood volume increased, probably doubled during pregnancy, and it is now behaving like a severe mitral stenosis. The
Okay.
question
So no, that is very important, Rafiq bhai, to assess the physiology, because we know that volume will get worse. So
Okay.
is the gradient getting worse or not? If the
Okay.
gradient is still mild, moderate range, then you need to think about that, whether you can let it go through the pregnancy. And
Yes.
that is a total information that we need.
Okay, so we have few questions. I'm going to start with pre-pregnancy. The question is, if this patient came to a physician and we found that there is mild mitral stenosis and she wishes to become pregnant, what will be the advice? That was one question.
Okay, so the advice is that pregnancy is not contraindicated. There are some absolute contraindication, relative contraindication. If this patient have never any problem and the current mitral valve assessment is mild, then you need to tell the patient that yes, pregnancy is allowed, but we need to understand the complications or possible complications that we may encounter. And it is a reasonable thing to do is assess the mitral valve by transthoracic echo and see whether the consequence of the mitral valve, that it all should line up. That means the physiologic assessment is mild, left atrium is not bad, PA pressure is good, and then you can say that probably okay. We never know, because these are biology with the patient. Some patient may not do as well as others. So it is a shared decision making, but it is not a contraindication to go into pregnancy.
And the patient that you presented, she is not short of breath. Will you give, what kind of medication will you give her to get her to the pregnancy?
So we keep the patient in a situation that if it is AFib, then rate control is very important. Tachycardia is harmful because of the problem with the diastolic filling. And then we try not to give diuretics unless too much symptomatic congestion. You assess and then follow up the patient and see every trimester, is there any worsening. We are lucky here because we have a high risk pregnancy clinic, because we communicate with the OB, not because of the mitral valve, but across board, any cardiac issues, we work with the high risk pregnancy clinic. And I'm sure that you can find high risk OB doc in Bangladesh as well and communicate and keep a good liaison.
Thank you, Hafiz. For the audience, Hafiz mentioned about valvuloplasty. Bangladesh actually have high experience with this procedure, probably because this procedure in the developed countries is very infrequent nowadays. So Bangladesh has a lot of experience in valvuloplasty. So if you have patients with mitral disease or any valvular disease, please make sure that they get cardiology consultation or evaluation. Thank you, Mark.
And about the on that note, many transthoracic echoes are good enough that we can do Wilkin score from the transthoracic echo. We don't necessarily need the transesophageal echo. However, for the valvuloplasty, it is good to make sure that there is no left atrial or left atrial appendage thrombus, because as you manipulate these gizmos, there may be dislodgement of the clot and thromboembolic manifestations. So I don't know how much time we have. We can go through the aortic.
Hafiz,
Yeah.
there are two more questions, because this is an interesting question.
Yeah.
So the pregnancy patient develops atrial fibrillation and requires anticoagulation. Can you clarify that? I know it's a big topic, but somebody has asked that question, and I thought that is important.
Okay, so first of all, for reference purposes, if you go to University of Southern California, and they have a Al Khayyam is the guy who has a lot of publications on the anticoagulation in pregnancy and valve disease, and you'll get a ready reference. So few propositions, and one is that you need to give anticoagulation and then long-term heparin it can be given, and then low-dose coumadin. So, believe it or not, after the period of organogenesis, some have used this. And as you know, the embryopathy with the coumadin during pregnancy is more when the coumadin requirement is more than 5 milligram per day. So you need to give this anticoagulation during this time, but as you go towards the delivery time, then you switch to heparin so that you can titrate off pregnancy, delivery, and then you can get this termination of pregnancy in a very safe way. But that is the recommendation.
I think there's one final question. I think it's a broad topic, but you could just give a brief answer. Is choice of between mechanical valve versus bioprosthetic valve? What will be the circumstances between the choice of the two?
Okay, this is actually a very, very interesting question. Like 5-6 years ago, we used to say for aortic valve, I'm starting with the aortic valve, then I'll tell you why I'm mentioning this aortic valve first. We used to discuss with the aortic valve and all that. The mechanical versus this, anticoagulation, coumadin, INR, all these issues versus the durability of the valve, because bioprosthetic valve degeneration and replacement again in 10, 12 years. Now a few things have happened. One, that the bioprosthetic valve durability has gone up. Now we can put bioprosthetic valve percutaneously so that you don't need an open heart surgery. And therefore, in our center, we are trying to exclude all mechanical valve for the aortic position. For the mitral position, it is not that easy because bioprosthetic mitral valve and then replacement of the bioprosthetic mitral valve by percutaneous is not yet the standard of care, but we are moving towards that. And I tell you one problem that even in Vegas, we have very few coumadin clinic now. So it is very difficult if you give a patient a mechanical mitral valve, how to manage them. But we need to have a dedicated coumadin clinic. I hope it answers the question, but it is a challenge. But I hope that one day we can just do bioprosthetic valve and then don't need to worry about these things.
So, Ahsan, shall we continue? It's an hour, because this is also a big topic. It's tough to make two valve disease at the same time, but that was a wonderful talk. And I think mitral stenosis is a major problem in Bangladesh, especially in the context of pregnancy. A lot of young patients get mitral stenosis.
And one thing I would emphasize that the other valve involvement is very important to assess. Mitral valve stenosis, whether there is a coexistent regurg, whether there is aortic valve involvement, and more importantly, how is the tricuspid valve, how is the RV, and accordingly decide. But thanks a lot for listening to this talk. It is a boring talk. Valve disease are rather boring, but we need to deal with this though.
Sir, though, sir, important topic, sir. It's a very, very important topic, sir. Mitral stenosis, especially.
Yeah.
Sir, অনেক কোশ্চেন ছিল। রফিক স্যার কি আর কোনো কোশ্চেন নেবেন স্যার?
আমি যে প্রশ্নগুলো পাইছিলাম এগুলো হাফিজকে বললাম। So Hafiz will have to answer, but Hafiz, you said boring. No, this was a fantastic lecture. I mean, I'm a cardiologist, but I don't deal with valve, and I could understand this lecture. That means it is a good lecture. It was a very good lecture.
So, Dr. Ahsan Khan, do you have any questions from the audience? Yeah.
Yes, sir. Many questions. আমি স্যার কিছু কোশ্চেন্স নিয়ে আমরা তাহলে স্যার আজকে শেষ করব স্যার। আমি কিছু কোশ্চেন নিচ্ছি স্যার। স্যার, কোশ্চেন ফ্রম ডক্টর মুশফিক রায়হান। অনেক কোশ্চেন স্যার, আমি কিছু নেই স্যার। ডক্টর মুশফিক রায়হান, why left atrium free of thrombus is a criteria for mitral valvuloplasty? Can we not manage this thrombus with anticoagulation?
So I'm trying to understand the question. The left
Well,
atrium.
let me phrase it.
Yeah.
I think that the question is a little bit in a roundabout way. I think the issue would be
Yes, sir.
that if there is a thrombus and patient needs intervention, some kind of intervention, what shall we do?
Yeah, okay. All right. So when there is a thrombus in the left atrium, or for that matter, in the left atrial appendage, we cannot do the procedure at that time, but we can give anticoagulation and we can follow up and then see the thrombus gone. Many times we see that with the adequate anticoagulation, we don't see. Remember, the anticoagulation we use, actually, these prevent the propagation of the clot. And we buy time and allow body's lytic system to dissolve the clot. So it's not, coumadin does not dissolve the clot, heparin does not dissolve the clot, but it prevents further propagation. Buy time in favor to allow the lytic system of the body to work on those, and we see that the clot disappears. If it is a very organized calcified clot, it may not go away.
Thank you. Ahsan, next question.
So next question. So why hemoptysis occurs in mitral stenosis? সাথে স্যার আরেকটা কোশ্চেন স্যার, in case of hemoptysis is due to mitral stenosis, how to approach with anticoagulants therapy?
Okay, so there is a lot of theories, right? That the back pressure, then the PA pressure goes high, then you can get this angiodysplastic changes. And then the one thing we know, those who have hemoptysis, they have high pulmonary vascular resistance. And therefore you need to work on those to prevent further hemoptysis. Hemoptysis and anticoagulation in atrial fibrillation, it is a problem. So the hemoglobin and then the degree of anemia and then degree of hemoptysis versus the prevention of thromboembolic complication, that is a toss-up. You need to think about the risk benefit. But in a frank hemoptysis, we try not to give anticoagulation and stabilize that first and then see.
So next question, sir. She's from Sunamganj, most difficult, hard to reach area of Bangladesh. Dr. Jyoti Das, তার দুইটা কোশ্চেন আছে স্যার। What are the indication of valvoplasty? সাথে আরেকটা কোশ্চেন স্যার, আপনি আনসার দিয়েছেন, তাও স্যার আমি একটু শুনতে যাচ্ছি। If a patient present with features of severe mitral stenosis, then what will be the management?
Okay, so I already mentioned that, but let me repeat this. Severe mitral stenosis with no symptoms is not that common. You usually see symptoms. And then you assess the severe mitral valve stenosis and then ask the patient for even exercise and see whether the exercise related PA pressure increase. But if the patient is already symptomatic and over symptomatic with severe mitral stenosis, then you need to do intervention. You assess the valve, which way you want to do surgical versus valvuloplasty, and you bring up these issues about Wilkins score, coexistent disease, and then there is any thrombus or not. So basically, that's the, in short outline that I explained already.
Hafiz, can I ask you something?
So last two questions.
Yes, and I have to.
Yes.
In Bangladesh, patients come when they have symptoms, but it is
Right.
changing. Patients are coming to physicians for other reasons.
Right.
And one of the things that I encounter, like some patient with heart failure say, I have no symptoms, which is actually not true, that they're leading a very sedentary life. Do you have any comment on that? Like somebody you think
Yes.
has severe mitral stenosis, but they should be symptomatic, but they are not symptomatic. What do you do?
Dr. Valentine Fuster from Mount Sinai, a giant in cardiology, his bedside teaching and his comment on the symptom issue is that the patient doesn't have symptoms because you did not investigate enough. And he says that, look at the common sense approach. What kind of work the patient does? A sedentary, wheelchair bound, and all these, you need to think about this. And he is very adamant that when you do the hemodynamics in the cath lab, we also bring up the issue about exercise related physiology, because patient probably has adapted himself or herself to a sedentary lifestyle that patient has forgotten what is the normal lifestyle. Sometimes that happens. Yes, we need to find out. Now, the goal is not to just bring up the symptoms issues, because you may ask, what about a 70-year-old and does not do any job and at home, why I need to tease out the symptoms? Why is that? You need to tease out the symptoms, not because you want to tease out the symptoms, because you need to see the underlying disease severity, which may affect his survival. Therefore, it is important. It's not just you are teasing out the symptoms because you want to tease out the symptoms. And the family members may think, why he's asking so many questions? He does not do any job. But the question is the underlying issue. And this is so true for severe aortic valve disease, for severe coronary disease. Then unless we tease out those, we may miss something that may cost the lifespan of the patient.
Thank you. Ahsan, anything else?
Sir, though there are many questions, but from me, last question, though issue is discussed, till then I'm again asking. Sir, from Dr. Saifullah Razin, what will be the treatment option of a pregnant lady having severe symptomatic MS in second trimester if anticoagulation is needed?
Yeah. So
last question, sir. Last question. Yeah. How to approach a pregnant lady with MS in treating her with digoxin, anticoagulants, diuretics?
Okay, so first of all, generic comment. Any drug we give in pregnancy, I would request you, if you are not comfortable, then look up in the literature, like everybody has a smartphone, you can look up that pregnancy safety. It is very easy to do. Diuretics first, in the case of pregnancy, diuretics is not contraindicated, but remember the volume shift is an issue. If you do too much diuresis, the fetoplacental circulation insufficiency can be an issue, but we need to consult with the OB doc as well. Second is the digoxin. Digoxin is safe in pregnancy, so there is no issue there, but you need to make sure that the patient does not have renal dysfunction, because digoxin is mainly cleared by the kidney. So if the renal failure is there, your dosing may be inappropriate and inappropriately high to cause this toxicity. So be careful on that. And then anticoagulation, I already answered that question, that yes, anticoagulation is indicated. And if you are going into planned C-section or vaginal delivery, you need to coordinate this with the OB doctor and then change to intravenous short-acting, relatively short-acting heparin therapy, so that the transition is safe and there is no bleed.
One
Okay,
book
sir.
that I
Thank
recommend.
you very much, sir.
Ahsan, I just want to make a comment. There is a book, it's the best book. Hafiz mentioned
Sure, sir.
University of South Carolina, Southern California, Yuri Al-Khayyam. He actually wrote a fantastic book on pregnancy and heart disease. And I think it is very, very important to get that book and read it. And I think they're coming out with a second edition, because it not only discusses heart disease in pregnancy, it also discusses the issue of medication use during pregnancy. And it is very, very important that every time there's a pregnant woman, we should not just assume that I know it. We need to look it up. These days,
and the important thing, Rafiq Bhai, that if you don't have the book, if you ask the question in the Google different ways, you will see the Al-Khayyam's writing will come up. I mean, honestly, we are in an age now that we should not have any excuse not to check online again. And I don't mind. I check online. In fact, in my round, in the CCU round, I actually assign one of the resident or fellows, we call it fact checker, that immediate Google. If I'm struggling to find any literature I cannot quote, I said, I read it, but double check. And then they immediately confirmed.
But I am going to repeat Hafiz's caution. The caution is when you Google it, please look at the source.
Yes.
The source material is very important. It cannot be just written by, compiled by somebody. If it is compiled by somebody, then you should go back to the original literature, then find out. And so that's very, very important.
And on that issue, let me say to you which sources are reliable. For cardiology, those who are interested in cardiology, the heart.org or Medscape, which is the UPenn now deals with this. This is a very reliable site. The heart.org is very good. And if you are internal medicine guy, primary care physician, but you want to read it like a newspaper, which is a good thing to do once a week or twice a week, go to the heart.org. You will see the headlines and you will probably enjoy many of the articles, and you may find it relevant to your practice.
Thank you.
And those who are interested in intervention, I would request you to go to tct.com.
থ্যাংক ইউ ভেরি মাচ স্যার। আমি আজকে এখন আমাদের আজকের অনুষ্ঠানের প্রধান অতিথি, আসলে যার মাধ্যমে আপনাদের দুজনের সাথে আমাদের পরিচয়, আমাদের আজকের প্রধান অতিথি চিফ গেস্ট প্রফেসর মাহমুদ হাসান স্যারকে আজকের সেশনটি সম্বন্ধে কিছু বলার জন্য অনুরোধ জানাচ্ছি। স্যার একটু আনমিউট করে নেবেন।
থ্যাংক ইউ ডক্টর এহসান, এবং আমি ধন্যবাদ জানাচ্ছি আপনার বিডি ফিজিশিয়ানসকে। আসলে আমি তো এই বিষয়ে সম্বন্ধে যা জানি সেটা ক্ষুদ্র এবং আউটডেটেড। মানে আমি তো কার্ডিওলজি বোধহয় পড়েছি 20 বছর আগে আর কি, কাজেই তারও বেশি হবে। তো যাই হোক, খুব ইন্টারেস্টিং। মানে আমরা যখন, এটা হাফিজ সাহেবও জানে, আমরা যখন মানে এই হার্টের রোগ পড়তাম তখন তো ইকোকার্ডিওগ্রাম ছিল না, তখন ছিল স্টেথোস্কোপ। এবং ইন্টারেস্টিংলি প্রফেসর শামসুদ্দিন সাহেব ঢাকা মেডিকেল কলেজের, উনি সকালবেলা এসে সেম রোগী দেখে বলতেন যে বাহ খুব সুন্দর সিস্টোলিক মারমার, আবার সন্ধ্যার সময় এসে বলতেন যে এটা তো ভালো ডায়াস্টোলিক মারমার, একই রোগী। তো এই ধরনের আপনার অবস্থার মধ্যে আমরা ছিলাম। সেইখানে এখন টেকনোলজির বদৌলতে আপনি দেখেন যে কত একিউরেটলি, মানে গ্রেডিয়েন্ট এবং অন্যান্য জিনিস যেগুলো আমরা ওই সময় নামই শুনি নাই, সেগুলো এসে গেছে। এবং উই আর ভেরি ফরচুনেট যে এগুলো এসছে, এবং এগুলো বাংলাদেশেও আছে। এবং বাংলাদেশে এগুলি নিয়ে আসার পেছনে আপনারা যে দুইজনকে দেখতেছেন আজকে, এদের একটা বিরাট অবদান আছে, যেটা ওনারা, আপনারাও কিছু কিছু বলেছেন। আপনার প্রফেসর হাফিজুল আহসান এবং রফিক আহমদ সাহেব দুজনে যে বিদেশের থেকে দেশের জন্য কিছু করা যায় না এরকম একটা যে ভুল ধারণা, আমার মনে হয় ওনারা দেশের জন্য যতটুকু করেছেন অনেকে দেশে থেকেও এটা করতে পারেনি বা করে নাই। তো আমি ওনাদেরকে কৃতজ্ঞতা এবং ধন্যবাদ জানিয়ে ছোট করতে চাই না, তবে তাদের অবদানের কথা অবশ্যই আমাদের মনে রাখতে হবে। ওনারা বছরে কয়েকবার করে দেশে আসেন এবং কয়েকবার করেই মানুষকে ট্রেন করেন, যাতে খালি উনি করে দিয়ে চলে গেলে তো শেষ হয়ে গেল, সার্ভিস মানুষে পাবে না। কিন্তু ওনারা লোক তৈরি করেছেন যারা ওনারা চলে যাওয়ার পরে এই সার্ভিসটা দিতে পারবেন। এটা রফিক আহমদ সাহেব ইলেকট্রোফিজিওলজিতে করেছেন এবং হাফিজ সাহেব ইন্টারভেনশনাল কার্ডিওলজিতে করেছেন। আমি নিজে ব্যক্তিগতভাবে জানি, এবং এইটা আমাদের দেশের জন্য কতটা উপকার হয়েছে এটা বলে শেষ করা যাবে না। তো এবং এই ক্লাসটা ওনারা নিয়েছেন, আমি আশা করি যে এইটাতে যারা অংশগ্রহণ করলেন বা ভবিষ্যতেও যারা, এটা তো ইউটিউবে থাকবে, অনেকেই দেখবে, এইটা যারা দেখবেন তাদের মধ্যে অনেকেই আপনার হার্ট সম্বন্ধে শিখবেন, এবং এর মধ্যে হয়তো কেউ কেউ কার্ডিওলজিস্ট হওয়ার জন্য ইন্সপিরেশন পাবেন। তা আমি আবার আপনার প্রফেসর হাফিজুল আহসান চৌধুরী এবং রফিক আহমেদ সাহেবকে ধন্যবাদ জানাচ্ছি, কৃতজ্ঞতা জানাচ্ছি, এবং বিডি ফিজিশিয়ানসকে ধন্যবাদ জানাচ্ছি। আমাকে আসলে তেমন কোনো কানেকশন না থাকা সত্ত্বেও আমাকে এখানে ডেকেছেন, আমি খুবই গ্ল্যাড এবং খুবই এনজয় করেছি। থ্যাংক ইউ।
এবং স্যার আমরা অত্যন্ত সম্মানিত হয়েছি স্যার আপনি আসাতে। আমরা অনুষ্ঠানের একদম শেষ পর্যায়ে আজকে আয়োজনে ছিলাম বিডি ফিজিশিয়ানস, আমাদের স্পন্সর ছিলেন এসকেফ, আমাদের লাইফ পার্টনার ছিলেন এফডিএস এর স্টুডেন্টস উইং এবং এক্সক্লুসিভ এডুকেশনাল এইড। আমি আবার আমাদের আজকের স্পিকার ডাক্তার চৌধুরী এইচ আহসান স্যারকে আন্তরিক ধন্যবাদ দিচ্ছি, এবং আমাদের অনুষ্ঠানটি আজকে সমাপনী টানার জন্য, সমাপ্ত ঘোষণা করার জন্য আজকের চেয়ারপারসন ডাক্তার রফিক আহমেদ স্যারকে আহ্বান জানাচ্ছি।
সবাইকে ধন্যবাদ। আপনারা সবাই শুনছেন যারা, সবাইকে ধন্যবাদ। আমরা এটা আরো কন্টিনিউ করব। এবং হাফিজ, থ্যাংক ইউ হাফিজ ফর দ্য টাইম এন্ড ওয়ান্ডারফুল লেকচার। মাহমুদ ভাই, আসসালামু আলাইকুম, থ্যাংক ইউ।
থ্যাংক ইউ, থ্যাংক ইউ,
Thank you.
And thank to all the participants. It is successful because you came.
জি, অবশ্যই।